So you are treating a DKA patient and you give him fluids, you give him insulin, you correct his potassium, you monitor his output. The patient starts to get better after some time, his ABGs improve, but a few hours later, suddenly the pH goes down again, bicarb goes down again. Now, why is that? One thing you need to understand about normal saline is that there is nothing normal about it. It has a higher sodium content than the serum, it has a higher chloride content than the serum, and it has a higher osmolarity than the serum. So when you were resuscitating your DKA patient, you were using normal saline or dextrosaline. Patient was in diabetic ketoacidosis, which is a high anion gap metabolic acidosis, and fluid resuscitation would help you get the patient back to normal. But during the resuscitation, you have now given the patient an additional acidosis to tackle with, which would be normal anion gap metabolic acidosis. That additional acidosis is due to hyperchloridemia, which was in the saline that you were giving. So when you are monitoring the patient for acidosis, you're doing his ABGs, you need to continuously check for the anion gap and the delta ratios. Delta ratios are important in this case. Delta ratio tells you whether the patient is in pure high anion gap metabolic acidosis or a mixed high anion and normal anion gap metabolic acidosis. If a patient has high plus normal anion gap metabolic acidosis due to hyperchloridemia, you need to switch fluids. Now, I would prefer plasmalite, but it is not available everywhere, so we can use ringer as well. So why hyperchloridemia is an issue? Firstly, it causes diagnostic confusion. It leads the physician to believe that the decay is not resolving. Secondly, it adds on to the high anion gap metabolic acidosis. It worsens the acidosis that the patient is already in. So due to this diagnostic confusion, the insulin weaning gets delayed as well, which in turn leads to longer ICU stays. There is also a risk of acute kidney injury and renal vasoconstriction with hyperchloridemia. So keep in mind, chloride is important in DKA. You need to monitor it. You need to monitor the ABGs. You need to monitor delta ratios, which would tell you if the patient is in mixed acidosis.